Preparing to post and sign off on this podcast as being ready. First of all, it's 12 minutes long. How can it be simple and 12 minutes long? And I just wasn't happy with it. So we're going to go at it again because this is extremely important and there's solid structures in it. So we've agreed we're dissatisfied. Easy agreement on that. We probably agree that the current structure is fatally flawed. Now that's where I keep saying that individuals are caught between the money and the treatment. We've introduced two things that are pretty straightforward. 10 proven management strategies, starting with membership and going through all that, and then having an individually friendly interface with personal health nurses and primary care. Some guidelines for the pathway forward. These are our best efforts in structuring for leadership and thinking how to think about fixing this thing that's such a monumental challenge. Moving forward certainly deserves one look backwards, and that is, why are we dissatisfied? We begin with individuals and the stakeholders have primary risk, and they get caught in the middle between the people that are paying and managing the plans and the people delivering the care. Is that real? Check this out. Anthem and Cleveland Clinic in Ohio, difficult negotiations, finally in December, struck a deal that impacts 5 million Ohioans. A little worse, across in Michigan, that Trinity stops accepting Humana impacts 800,000 people. They got to find other providers of care. Don't you? I hate that word providers. I used to think in terms of doctors and professionals. All I need over here is better health care, and lower costs. I want to be a member of something that brings me that. We certainly know how it works and how it feels, and it's dissatisfaction. Stop looking back, and we're going to move forward with an overly simplified plan of attack. Here's a possible structure for thinking, planning, and acting. On the left-hand side would be populations that are the size that we can manage health in. The next is how do the health professional ratios fit those population of service? And then how many places do we need to put this in place? That's where the challenge really becomes. So populations. I say population when you're sick, one-on-one. It's not a group activity. But the second level is hundreds. Employers over 50 lives are all in the insurance business. So that strata really fits. And they stay over at risk for their populations as they go up into the thousands and into the hundreds of thousands. Not much reason to go beyond that because there's only 10 places in the country where the city is over 1 million people. RNs 1 to 7, 8. AI just got me that. I've been thinking in terms of 1 to 100, which is real interesting because it fits really well. PCPs, we got 1,100, and NPs, we got 1 to 866, and PAs, we got 1 to about 1,000. Those are the way the people are spread. The professionals are spread through stakeholder number 5, which are the health systems. Here comes the interesting challenge. There are 340 places in the country that have over 100,000 people in them. These are cities, and they're about a third of the population. If you look at the metropolitan statistical areas, it's still about 350, but it covers about 2/3 instead of 1/3. So it's a matter of how you aggregate the surrounding towns. There are 500 communities between 50,000 and 100,000 with 35,000 people. And then based on which way you look at it, we know there are 18,000 additional incorporated places that are under 50,000. And whether you look at it from the metropolitan statistical view or the community actual incorporated places view, it's either 2/3 of the people live here or 2/3 her. I'm pointing to it like you can see it, or 2/3 are in the smaller one. So we have 6,120 hospitals with 2.3 beds, which 2.3 beds is probably too rich. But that's how we can put our thinking together to drive this forward. That's the structure: populations, professional ratios, and how do we deploy them within the local community. Well, reviewing this for posting, I have gone out on a limb. Watch this. Individuals need help with healthy habits, social determinants of health, and they need a friendly, efficient interface with health systems. I've taken some strong positions here. First one is major commitment to health and healthcare is one-on-one and populations being local. That's key. I think we're going to have some struggles accepting or agreeing on that. The second is realistic assessments of advances in data communications and so forth. This second one is an outlier to me, saying we have no idea what's happening in technology and how it's going to affect healthcare and how that's applied based on one, which is the local nature of healthcare. Understanding the complex interactions between individuals, their health, their treatment, their professionals, and money. That's where all this stress comes from that causes the dissatisfaction. Those have got to be built across collaborations, in my opinion. And finally, the fundamental is assume shortages of all four and the number three of professionals. We will buy all the healthcare someone else will pay for, and they will sell all the healthcare someone else will pay for. Applying those fundamentals to the next level, always starting in the same place with individuals and their infrastructure. We're all in charge of our own health. It's hard to imagine, hard to admit, but yeah, we got to eat the right things, exercise, stretch, do the things we do, especially as we age. Employers, you're the insurer of last resort, and it's time to step up and do something different than what's been handed to us with messing with plan design and contracting and all that. Federal government, demographics are not our friend. We can't transfer the risk. Medicare is enormous, and deploying all of that locally is one big challenge. State governments, local governments, wow, what potential. It's just amazing. And health systems, when we look at that, they're the most logical place to get membership put into a local organization with financial risk and ways to manage it. That's how it looks to me. Insurers, you hold the strategic keys by not actually trying to deliver care and manage delivering care, but actually managing the complex um, interactions that go on within the stakeholders. Structuring a pathway forward is basically starting with the individuals again, their infrastructure assistance, and community leadership driving forward better health, better healthcare, and cost, assisted by the 10 real population health management strategies listed below. You're getting used to seeing those, but it's all about membership, communication, help, pricing, the whole deal. It's right there to be done. What's the summary? Our purpose was simple. I don't think we made that. There is probable agreement with our unsatisfactory current situation. And slide 3 says three things. Demands flipping the system to focus on individuals, summarizes health professionals, and outlines communities' relative sizes. Really sets the stage in slide 4, formalize how complicated it is, and we trial launched by stakeholder. My hope is that within all this complexity, we have the progress towards structures supporting discussion, decisions, actions, and collaboration. Want more detail? We've written a lot of books about it, but I think we have possibly chopped out a primitive path forward that can be approached and traveled by individuals, individual communities, and the larger organizations of governments and employers that have the risk along with the individuals. Thanks for listening. This is complicated, not going to be an easy trip.